Hi guys, welcome to this video. Thank you so much for being here. I greatly appreciate the time you guys are taking out of your life to watch these videos. And a lot of questions that have come to me through my time pertaining to the pain referral patterns is, where did these come from? How did they get started? Are these just a figment of your imagination? Did you just make these up on the spot in order to, go along with the technique in the courses? And no, I didn't come up with these at all. These are not a figment of my imagination. This is all based on evidence-informed research and science. So the history of the pain referral patterns is sort of twofold. A long time ago, early on in my career, at the time of shooting this video, I've been practicing for about 23 years. And early on in my career, within the first 3 years, we all have those pain referral charts in our office, those trigger point pain referral charts with the really ugly colors that you see. Anyways, I had a lot of patients that were looking at the charts and they were saying, that's not me. That's not the discomfort that I'm feeling. That's not my pain. That's not what I feel. And I would have a number of different colored markers in my room, and I would hand a marker to a patient, say, go and chart your pain, or go and chart what you're feeling. So they would put an X on where they were initially feeling it, and then they would chart out their own referral pattern for themselves. And the trigger point charts, they got really messy after a while. So I had a number of these trigger point charts that were all getting marked up by my patients. And in my office, I just kind of got used to what their referral patterns were, and I completely forgot about what the typical, Referral trigger point patterns were. And anytime that I had a patient in my office that was complaining of a peripheral joint injury or a vertebral column joint issue, I would just automatically, in my mind, I would bring up that pain referral pattern that a number of patients had told me and had confirmed. And I would inquire to that new patient about that referral pattern. They would usually say that yes, that was it, and I would continue on and I would treat them appropriately. Well, we jump ahead about 15 years, and I'm doing a whole bunch of research into ligamentous articular strain technique. I'm looking at increasing the evidence-informed research supporting it, and I come across some readings on prolotherapy, because in our office, with the physicians that are in our office, they do regenerative therapies such as prolotherapy, PRP. In Canada, we can't do stem cell, but down in the States, you can. And I started reading and researching about George Hackett and Gustav Hemswell. Now, these guys in the 1950s, if I believe correctly, they were sort of the originators of prolotherapy, and they were doing research on ligament pain referral patterns. And they did something like 20,000 injections on over 1,600 patients over the course of maybe like 5 years to a decade. There is actually a research paper from the 1950s on the observation of pain produced by injection of hypertonic saline into muscles and other supportive tissues that you can find online. You can download and read. But they went through and they charted out these typical pain referral patterns that they were able to document from the patients that they were injecting the hypertonic saline solutions into to elicit these pain referral patterns. Now, in looking at their charts that they created, that George Hackett created and Gustav Hemswell created, they very closely resembled what my patients had been charting on all of my trigger point charts over the years. So looking into their research, not what my patients had said, but looking into their research and what their referral patterns were, You know, I gained access to a lot of their images that they had sort of documented, and some of these images, I'll throw a couple up here on the screen, they're just absolutely, you know, terrible looking images. They're just, you know, stick men with dots around the areas and trying to decipher, you know, was it, you know, sort of superficial discomfort? Was it deep discomfort? It took a long time to differentiate, you know, exactly what referral pattern went with what image. And I had sort of thought, you know, it'd be really nice to have these images in my office on the wall as a representation of their work, and it would allow me better communication with my patients about what they're experiencing. So I searched everywhere because I figured, you know, if the trigger point charts were everywhere and they were so easy to find, you can find them on anywhere on the internet, I figured, you know, these ligament pain referral patterns, they had to be somewhere. I searched everywhere. I went onto all the different websites. I searched everything. I searched tons of medical areas on the internet, and I couldn't find any. So what I did is I hired a anatomical graphic artist in order to create each individual image based on the research of Hackett and Hemswell, and I had the images created. And then I had the images created into the posters, and I put them up on my wall. And for a long period of time, I just had those posters. They were just, you know, printed 2 posters on my wall. And I would use those in my practice with my patients, and it greatly increased the communication that I had with my patients, and my patients were able to better describe exactly what they were feeling, how they were feeling it, where they were feeling it from. They were able to use the pain maps very effectively in my practice. But I treat a lot of other medical professionals. I treat a lot of massage therapists, physios, chiros, occupational therapists, physicians also. And they were interested in the posters too. And they said, well, where did you get your posters from? I said, well, they're my posters. And they, well, we know that they're your posters, you bought them, but where did you get them from? I said, no, these are my posters. I hired the artist. We mapped out, you know, the posters, we created them, these are mine. And they started inquiring about, you know, they'd like to have them in their offices. So that's how the ligament pain referral pattern posters all got started. It started about 20 years ago with me communicating with my patients a little bit more precisely and specifically about what they were feeling with their peripheral joint injuries and their vertebral column injuries, and then finding the research from Hackett and Hemswell. I've also done a lot of research through PubMed and other sources into pain mapping. There's actually a lot of information on pain mapping and how they advocate using pain maps as a diagnostic guideline and as a research tool. So I find that these are tools, and they're really amazing for, again, opening dialogue, increasing communication, and being a little bit more specific and precise and effective with my patients about exactly what their experiences are and if we're able to change those. Now, in having those pain referral charts, you'd better know how pain referral happens. And I started asking a lot of people while we were developing these pain referral images about what their ideas and what their thoughts are, what their education was about referred pain. And some of the stories I heard were just absolutely amazing. It's like a Star Wars trilogy about how pain referral happens. And it took me a long time to actually go through and contact a number of physiatrists and neuroscientists in the world. And I was blessed to have made contact with a professor whose name was Thomas Graven Nielsen. And he was kind enough to send me about a 45, 50-page research document on referred pain and describing the neurophysiological model for referred pain. So I will post this page for you to download so that you can actually print it off and utilize it with your patients, because this is how pain referral occurs. And whatever myth and trend, whatever story you've heard when you were in school, or whatever you've read through some textbook or something, this is the current understanding of how pain referral happens. Typically what happens is, as I've talked about in the previous video, there may be damage, there may not be damage. It could be a perceived threat, a perceived situation of unsafety, and it can be a psychological influence, it can be a biological influence. So there could be some mechanism of injury that has happened to the physicalness of your patient. There's a danger and a threat message that gets sent up through the peripheral nervous system, through the dorsal root ganglion. And at that dorsal root ganglion, there's a bit of an inflammatory process that happens, a hypersensitization that occurs. And that hypersensitization can actually travel between 1 to 3 nerve roots up and down. Now, those nerve roots innervate different tissue. So, for example, if I have a local pain in my shoulder, and that goes to a dorsal root ganglion of about C5-6, and then it sort of hypersensitizes a C6-7, well then whatever tissue that is innervated by C6 and C7 further on down, so it might be down through the forearm, it might be down through the thumb, the index finger, through the middle long finger, those areas will feel some discomfort also. And it might be a numbness, tingling, pins and needles, it might be a lack of sensation, it might be a sharp shooting referred pain, it might be a burning sensation. But that threat danger message is sent up, it irritates the dorsal root ganglion, that can irritate anywhere between 1 and 3 levels above and below. And then you get the pain message, or that neurological message that gets sent back down to the tissue that causes that referred pain. And that is the neurophysiological model for referred pain. And in this sheet, there is 7 key features of referred pain. And so the first one is that referred pain is felt distant to the initial local pain. So, you know, if I initially have local pain in my shoulder, the referred pain is always felt distantly. It is semi-directional, so it only goes one way. It's usually a deeper sensation than what the local stimulation is. It needs a higher stimulus than the local pain. So the local pain, it doesn't take too much to irritate it. But when that stimulus gets a lot more intense, then you're going to start feeling that referred pain a lot more. The referred pain is also, it's delayed. So the local pain happens first, and then it takes some time for that hypersensitization to occur through the dorsal root ganglion, and then you start feeling that referred pain a little bit later on. The referred pain, although it comes second, it goes first. So when you're going through a rehabilitative process and you're starting to have some healing occur through the physiology, the referred pain goes first, and then the local pain is what you're left with that will diminish afterwards. And then the stimulus for the referred pain site isn't needed. So for example, if you were to go and try and stimulate the distal portion that your patient was experiencing a referred pain in, it wouldn't elicit the referred pain, because that's not the area that is hypersensitizing those dorsal root ganglions. So, so this is a really nice sort of consensus of, or just a nice explanatory model for referred pain, how referred pain happens. I would love it for you guys to print that out, to explain to your patients anytime that they're feeling referred pain. You know how, you know, some patients will come in, they'll say, you know what, it hurts over here, this is initially where it started hurting, but then now I feel it over here. You know, how does that happen? And a majority of therapists, we all start trying to look for some type of structural connection. Is it the fascia? Is it the ligaments? Is it the muscle? Is it something else? What is it? And it's really important to relay to your patient that this is a neurological, this is a neurophysiological experience that you are going through, and this is typically how the neurophysiological model for pain occurs. I go into a little bit more depth about that through the videos, through these separate online courses. But for the most part, again, you can download this paper, you can print it off, you can explain it to your patients, you can hand it to your patients, they can walk away. Again, patient education into pain and pain science is absolutely a must in our profession. And it's been really shown, the research has shown that when you educate your patients with pain science, they understand it a lot more, it makes them more proactive, it makes them feel that their body is a lot stronger, it's not weak, it's not damaged, and that there's a potential for a change to occur, a positive change to occur, and that the reality that they're experiencing right now might not be the reality that they experience 6 months to a year from now, and that there's a potential for improvement in quality of life. And that's the whole thing that we're trying to accomplish with our treatments in our practices. So I hope that you enjoyed that video on a little bit of the history about how the pain referral patterns came to be, a little bit of the history about my patients determining what their pain referral patterns were, and looking at the research from Hackett and Hemswell and recognizing that the images from my patients were very similar, if not exactly the same, as what Hackett and Hemswell had documented in their research, their 20,000 ligamentous injections. And then, the information about that I'd received in the research paper from Thomas Graven Nielsen, who is who's a neurological professor, and just the neurophysiological model for referred pain. Again, that's how referred pain occurs. So thanks for watching the video. In the next video, we're going to start getting into the specific pain referral patterns for the different areas, and we'll talk about some patient stories to go along with those to provide some context for that. So enjoy the videos, and I will see you in the next one. Thanks, guys.